Oh, thank you. We shall wait till 8 o'clock and we will start. Is that fine? Yeah.
Yes, sir. Perfect.
ನಾನು ಅಲ್ಲಿ ಇರ್ತೀನಿ ಒಂದು ಚೇರ್ ತಗೊಂಡು ಹೋಗ್ತೀನಿ ಹಾ ಅದಕ್ಕೆ ಚೇರ್ ತಗೊಂಡು ಹೋಗೋಣ
Okay, I guess who is going to be volunteering first?
I'll volunteer, sir, first, if
okay.
it's okay with everyone.
Yeah. I mean, yeah, sure. So basically, what I am planning is, like before only, we will just conduct Viva as such. But at any point, you guys, if you want to stop and discuss something, or also it's okay, because I don't want it to be like, just asking questions and answer. If you want to do it in any other way in between or after each topic, maybe we can stop, maybe discuss about it for 2 minutes or 3 minutes, then go to the next one. I have basically tried to cover the major topics, but divided into like 4 or 5 sessions. That's it. So small sessions as such, so that we can cover everything. So basically, what we are planning is, because we gave a time before, I think probably you guys had time to go through the whole of the topic. Plus, after this also, you can go through few of the things, maybe which you think that you wanted to revise more, so that you can finish off this session for the exam. That is the whole idea behind
Yes, sir.
Not about how you are going to answer here or anything. It's just about how much you people remember and how much you want to revise more, just to give an idea about that. So don't worry, take it easy. Just go through the questions, see if you can answer it. If not, you can write down the points which is lacking behind, so that you can revise it further. So shall we start? It's 8 o'clock.
Yes, sir.
Okay. All right. So good evening. So today our topic is pregnancy and anesthesia, or obstetrics and anesthetics, basically. So my first question. So basically, before going into the questions, so these are the things which I have seen that can come. So these are basically the topics which can cover for the exam. So physiological changes of pregnancy, antenatal assessment of the pregnant woman, anesthesia in early pregnancy, medical diseases complicating pregnancy, labor analgesia, anesthesia for cesarean section, failed intubation in obstetric surgeries, emergencies in obstetrics, AFE, preeclampsia, PPH, APH, tocolytics, uterotonics, and neonatal resuscitation. So pretty much these are, if you can cover the whole these things, I think most of our topic will be covered. So just wanted to give an overview. Okay.
Yes, sir.
Going into the question now. Okay. So what are the physiological and the anatomical changes in pregnancy?
So good evening, sir. Physiological and anatomical changes of pregnancy. So pregnancy induces a lot of changes, and I like to enumerate them system by to start with CVS. There is a hyperdynamic circulation, and there is a increase in heart rate, increase in stroke volume, and so increase in cardiac output. There is a decrease in systemic vascular resistance. So They are
By how much do
prone
you
for
know?
hypotension.
How much SVR can decrease by how much around?
Value exactly, I don't know. So
Yeah, it
normal
will
it is around
decrease by
1000 to
around
1200.
15%, 15%. Yeah,
15%
yeah.
decrease.
And what is
Okay.
the reason? What is the reason behind decrease in the systemic vascular resistance?
It's vasodilatation because of estrogen and progesterone effect,
Yes,
leading
and
to decrease in the
also
uh,
due to the development of intervillous spaces.
intervillous spaces.
Yeah. Okay. Please go ahead. Sorry.
Then, then there is a hyperdynamic circulation. So there is a increase in left ventricle also. So it shows on ECG as a
Yes.
left axis deviation with a left ventricular hypertrophy, and you may see the T flattening or T inversion with ST depression as well
Okay.
in the ECG as far as CVS is concerned. Then coming to the respiratory, in the respiratory field, there are anatomical changes. There is a dilatation of airways, and there is also at the same time there is a mucosal engorgement. Then the diaphragm is shifted up to 4 centimeter above the normal level,
That is
and
from
chest
which week do you
circumference.
see that? From which week do you see that? The
That
diaphragm.
occurs after 20 weeks. Sir.
Yes. Yeah.
Yeah.
Okay.
And chest circumference increases, thereby reducing the thoracic compliance, but the lung compliance remains the same. And then as far as volumes of lungs are concerned, there is a increase in respiratory rate, there is an increase in minute volume and tidal volume, but the total lung volume and vital capacity remains the same.
Yeah.
And respiration wise, their FRC reduces, so they are more prone for hypoxemia. Sometimes even it goes below the closing capacity, CC.
Yes.
Then coming to GIT, mostly their mortality increases. Their main concern from our point of view is low esophageal space. Low esophageal sphincter becomes lax, and their gastric pH also becomes more acidic. So they are prone for aspiration. Their gastric emptying time is delayed because of hormonal effect. Then coming to renal physiology, there is an increase in renal blood flow. There is increase in glomerular filtration rate, which may lead to decrease in serum creatinine and BUL level. So while any renal problem, we should keep that in mind that sometimes even the normal may be more in these patients. So then they have a glycosuria and proteinuria. As far as the renal is concerned.
Yes.
Then hematology is another thing where there is a lot of changes takes place. There is a almost 60% increase in plasma volume. Even the RBC increases, but relatively the increase in RBC is less as compared to plasma volume, giving rise to dilutional anemia. Then their WBC also increases from 4 to 6,000 to almost 10 to 12,000 per cubic millimeter. Then their platelet reduces, and coagulation factors are also affected. They are reduced except 11 and 13. So their coagulation profile is delayed, which includes BT, PT, APTT. Then there is a reduction in the albumin, so there is a oncotic pressure also reduces. Then about endocrine, there is changes in sugar glycemic status because there is a insulin resistance as well as insulin secretion reduces, and at the same time steroids increases, giving rise to hyperglycemia or pregnancy induced diabetes. Then they may show the reduction in thyroid functions as well. Then coming to musculoskeletal, there is a lot of laxity of the joints and tendons, and as far as musculoskeletal system is concerned, that is again to accommodate the fetus and makes the pelvis preparation of the pelvis for the normal delivery.
And it is due to the progesterone.
it reduces the progesterone.
Yeah.
And as far as CNS is concerned, from our point of view, there is a hepatic vessels, epidural vessels engorgement, reducing the epidural space, and there are chances of rupture of epidural vessels during this thing. They are reducing the space, so they are also prone for a high spinal, high epidural action, and their MAC also reduces, so they can undergo the under the inhalational anesthesia quite fast. So these are the physiological and anatomical changes which are important from our anesthesia point of view, which takes place during the pregnancy. So.
Okay. So one thing I just wanted to tell you, you had said about the factors. The factors decreases. Actually, the factors increases. The 7, 8, 9, 10, and 13. So because that's why it's a hypercoagulable state, and there is increase in hyper. It is a hypercoagulable state. Yeah.
Sorry, it increases except factor 11 and 13.
Yeah, I just wanted to point out that's all. And when you tell about the respiratory, I think you should briefly mention how much if you can try to explain, like the oxygen consumption increases by 30 to 40% minute volume. How much, at least if you can remember that, it will be excellent, because that will fetch you more this thing. And yes, so okay. Now coming to this particular, if you can see it in the screen, the question.
Sir.
So it's a primiparous patient with a BMI of 55. It presents with a high risk anesthetic in the clinic at 34 weeks gestation. She is hoping to have a normal delivery, but if she has to be taken in for a cesarean or anything, so that's why they are showing to an anesthetist in the anesthetic clinic. Now, can you please, since you have already described about the physiological changes in a normal pregnant patient, can you please compare it with including obesity, how it is going to change the physiological changes, what you have enumerated, and what are your methods of assessing a pregnant obese patient, and what will be your things you should be careful while anesthetizing if the patient has to come for a surgery? Yes.
So
you can start with the physiological
obesity
changes in an obese patient, please.
Yes, sir. So obesity itself is a problem, and then there is the obesity itself leads to a lot of physiological changes.
Yes.
In all the systems, CVS, RS.
Yes. So can you just
drug
start with the
metabolism,
cardiovascular system? Yeah.
In the obesity, as far as CVS is concerned, there is these patients, they have a hyperdynamic circulation. They have a increased demand. So to fulfill that, there is an increased heart rate, and their increased heart rate and contractility. Their SVR increases in obesity. Actually, they are mostly hypertension. They are mostly hypertensive, and so if there is a pregnancy along with that, then they are actually prone for pregnancy induced complications, like they are prone for going into preeclampsia. Then
their mean arterial pressure
RS
will be high.
Will be at a higher side, sir.
Yes.
Then they are more prone for myocardial complications. They are more then as far as respiration is concerned, their obesity adds to the respiratory problem. There is already reduced FRC in these patients, and then obesity further adds to the reduction of FRC, and they are more prone for hypoxemia. So their desaturation time is very less during the induction or any episode happening in perioperative period. And then
what about the tidal volume?
Tidal volume reduces. They try to compensate by increasing the respiratory rate and try to maintain the minute ventilation. Then they may have they may show the pulmonary vascular resistance increase with the pulmonary hypertension and right heart strain as well, because of the obesity and increased volume due to the pregnancy along with the obesity.
Okay.
Then as far as respiration is concerned, their FRC, I already mentioned.
Yeah, you already mentioned
then
that.
GIT, yeah.
Yes.
Then GIT wise, sir, their again their gastric emptying time is delayed, and they're already in the pregnancy. There is a low esophagus, so it is same. So they are more prone for aspiration pneumonitis in a perioperative.
What about the endocrine?
Period. Endocrine systems, sir, they are more prone for developing the diabetes. Their hyperglycemia, sugar control gets disturbed in the endocrine, as well as they apart from sugar, they have a problem with the thyroid also. So they are prone for hypothyroidic signs when they have obesity as well along with the pregnancy. Then then
and the
renal,
hematology, right?
Hematology wise, the dilutional anemia will be insufficient to provide the basic metabolic rate requirement and oxygen requirement, which already is at a higher side, and that will cause the strain on the respiratory system as well as the cardiac system.
They become more hypercoagulable than the normal pregnant ladies because of the adipocytes, they release adipokines, which are like a plate, it impairs the fibrinolysis. Then it also releases leptin, which is a platelet aggregator.
Leptin, yes.
And also interleukin 6, which increases the production of clotting factors from the liver. So these are the three things that adds on with obesity.
Coagulation, obesity.
Yes. Yeah. Yes, so we have to be more careful with their hypercoagulation.
Careful with their hypercoagulation.
Yeah. So in this condition now, since you have, so what all, how will you conduct a pre-anesthetic checkup for this patient?
So pre-anesthetic checkup, I'll start with the thorough history. Yes. And I'd like to assess in the history, I'd like to assess both the pregnancy as well as obesity. And from that point of view, I'd like to ask what is the at what stage of the pregnancy patient is that present, and is the patient multiparous or a primigravida, and then does she has any previous complications regarding during the previous pregnancy. Then I will ask her about is she on any medication for any pregnancy related problem. Then from the obesity point of view, I'll ask her about the effort tolerance. I'll ask her about the sleep pattern, whether she's sleeping properly or not, whether she's having daytime insomnolence and fatigue and tiredness. And then I'll ask her about,
you know, the classification, how to classify her sleep apnea? The
obstructive sleep apnea classification, I don't remember, sir.
Okay, no problem. Do you remember the mnemonic bang? So just keep that in mind. So
bug,
stop
bug
bang.
Something. Stop bang. Yeah.
Okay, it's okay. Sir. You can go ahead, please.
Yeah. Then after thorough assessment about the pregnancy and the obesity status, like I'd like to assess her airway. Assessment after history, I'd like to go for assessment. In assessment, my basic examination will be about the weight and calculating the BMI. Then I like to note her pulse rhythm rate and then blood pressure. And I'd like to assess her system-wise CVS, RS.
No, airway in particular. What
airway assessment? Airway assessment. I like to assess the jaw opening as far as Malampatti grading is concerned. Then I like to know her neck movements, Then I like to know her neck circumference.
Yes.
Then I like to also know her mandible, whether she is able to protrude and retrograde movement of mandible. And then I like to know the thyromental distance in this patient, because they're prone for a difficult intubation, and as obesity and pregnancy is combined. So again, I'll have to be more cautious regarding the aspiration also during the intubation. So I'll have to plan intubation properly. So airway assessment has to be thorough, considering the combination of pregnancy and the obesity. Then apart from that, I'd like to, after thorough examination, I'd like to investigate her. From investigation point of view, I like to know the complete blood count. Then her platelet, I'll be more interested in hemoglobin and platelet count as well, as far as and WBC, whether she is having any ongoing infection, as it is WBCs are raised in this patient. Then apart from complete blood count, I love to know her coagulation profile. Then I like to know a renal function test and a hepatic function test. Then glycemic control, if she is on any anti-diabetic or something. So I'd like to know her HbA1c as well. Then ECG and X-ray, I'll also like to see her. I'll also like to get her 2D echo done, so as to know the cardiac condition. And I'll be more interested in urine examination, 24-hour urine examination, whether there is proteinuria and glycosuria. So these
Do
are
you
the
need to do a 24-hour urine
investigation.
protein in a pregnant lady?
So, yeah, 24-hour urine protein I'll be interested, because more than 1.3 gram per liter per 24 hours, then that may indicate that patient may be having a pregnancy-induced hypertension, PIH.
Okay. So what are the specific obstetric risks associated with a raised BMI in pregnancy? So when she comes, so what are the obstetric risks associated with it?
Obstetrics risk is a patient is prone for being, considering the obesity as well. So patient is prone for a PIH. Patient is prone for a diabetes. Then patient is prone for perioperative problems, like she can give intubation problem. There can be a coagulation problems. The patient is prone for a more perioperative complications, like blood loss. Patient is prone for uterine hemorrhage or atonic PPH. Then or even patient is prone for antenatal hemorrhage. Then patient is I can face the problem of maintaining the oxygenation in this patient during the intra-op as well as in the post-op period. And as the patient is hypercoagulable, so there is always a risk of DVT thrombosis and even the other problems, like they are prone for hypoxemia during perioperative period, maybe because of lung problem itself, or maybe because of amniotic fluid embolism, or pulmonary embolism. They are more prone for that. Then they are more from aspiration pneumonitis.
Yes.
So these are
what
the
will you
problems.
communicate to the patient now, since you have assessed all these things? So what are you going to communicate to the patient?
So I will inform all the risk involved in the perioperative period to the patient. I will ask her to. I will explain the intra-op and post-op complications, and I'll explain her the requirement of HDU or ICU stay in post-operative period. I'll explain her regarding the requirement of blood transfusion. and overall risk, high risk in the procedure.
Will you consider speaking with the intensivist as well, potentially, if she has to be in the post-op
yes, sir. I
period?
like to involve intensivist as well for the post-op period help, and even from surgical side, I like to involve senior surgeon and even a anesthesiologist colleague to help me to handle this case.
So, Manish?
Dr. Deepak has raised hand.
Yeah, sir, just need to clarify one thing that you asked what will we need to communicate to the patient.
Yes.
So this communication means to explain the risk involved, or we just need to communicate the instructions which we need to give to the patient. This also
No, we have to
under
always inform the risk, because that's why probably they have sent a patient with a BMI high. So we have to tell the examiner how, as a consultant in anesthetics, we are going to explain to the patient or the patient's relative, including the relative, about the potential risk or whatever it is, so that they will know before in hand what they're, what we are exactly planning for.
Okay.
And
so we
even
need not tell,
we can
not
also
instruct
discuss
the
about
patient.
the
Sorry.
mode of anesthesia, what we are planning, and
Okay.
what are the alternate methods of anesthesia which we are going to plan. And in detail, then we have to describe the complications that may occur with each mode of anesthetics as well.
Okay, so we need not give the instructions like she has to be the fasted, she has to take the antacid prophylaxis.
Yes.
This is all part of communication.
Yes, definitely. But that even we have to communicate that. But anyway, this patient is not already posted for the surgery, so more emphasis should be given to her increase in BMI and potential
the risk involved
for the surgery. So that is the main point here, what we are trying to attribute to.
Okay, thank you.
Yeah.
Yes, sir.
Okay. So yeah, so I think we will wind up with that session. Otherwise, we will not go forward with other topics.
So one small doubt. Hello.
Yeah.
So what about labor analgesia? Do we explain her now itself about the labor analgesia options available for painless?
Definitely, we will explain about the labor analgesia, because she is not posted and she wants a normal delivery. So we will always explain to her about the labor analgesia. We will explain different kinds of labor analgesia, and we can give her options about it. She can ask all sort of questions. So in communication, literally, it comes to all kinds of questions regarding the peripartum period and related to anesthesia. We can explain to them.
Okay.
And yeah, and we have to document that as well.
Yes, sir.
Yeah. So anyone else wants to go with this question? If
can I go?
Yes, please.
Yeah. So this is a 25-year-old pregnant woman with 20 weeks of pregnancy presented with abdominal pain and signs of acute appendicitis. So differential, the surgeons have posted her for laparoscopic appendicectomy.
Yeah. So I just written a couple of questions, a few questions as well. So
yes, sir. So the differential diagnosis of abdominal pain in pregnant patients, I would like to classify it based on the system wise. First is I would like to keep it as obstetric and non-obstetric causes. Obstetric causes, there can be false contractions, there can be impending to say termination or bleeding inside the intrapartum, intraplacental bleeding or intrapartum bleeding. Antepartum hemorrhage also can present as pain abdomen, and there can be non-obstetric causes like renal stones, acute cholecystitis, and appendicitis, which are the more common causes of pain abdomen in pregnant patients. Hello, so
Yes, yes, I can hear.
Yeah.
Yeah, go ahead.
And
Anything else you want to
can
add? Yeah, you can go ahead. Go ahead.
the other infective causes can also be there, like urinary tract infections, very common in pregnant patients presenting with pain abdomen only, and patients with chorioamnitis or any procedures done during the for obstetric causes, like some patients undergoing chorionic villus sampling, they might have a small bleed, that pressure, and more of the uh, obstetric causes. First, I would like to rule out all the obstetric causes of pain abdomen. Simultaneously, I would also be looking for other causes of the pain abdomen.
Okay.
Uh,
And now coming to the assessment and optimization of this patient.
Sir, she is in severe pain. So first, my management will be pain, secure in whiteboard cannula, and assess her pain, score the pain. Simultaneously, I'm activating the operation theater as well as a multi-modal approach for pain management. And my senior colleague also been informed, because I would need to intubate the patient. Being a pregnant patient, always a difficult airway, a difficult cart to be kept in place, and all the difficult airway cart is kept in place. An obstetrician team is required inside the OT. A neonatologist is also informed, because the surgery will be involving general anesthesia, and how it goes about, how bad is the appendicitis, we have not yet assessed, sir. So we would just do an ultrasound to be done on the way. First, manage the pain, giving her milder pain analgesics like paracetamol 1 gram IV, and assess her dehydration. Start her on Ringer's lactate solution at around 50 to 60 ml per hour, and look for other vitals like maintaining her airway, giving oxygen, trying to manage her on the left lateral position or whichever lateral position she is comfortable, and putting her on an oxygen mask, giving her securing her one more IV cannula, two wide bore IV cannulas to assess her hydration again. Then okay. Then I would be moving her into the ultrasonography. In the presence of an obstetrician, I would request her to document the where is the fetal heart sounds, where is the exact uterine size, and do a pervaginal examination to rule out the other causes of uh, pain abdomen. Then coming to in the ultrasonography, I would like to look into any free fluid collection is there around the appendix, or is it suggestive, any feature suggestive of rupture appendix?
No, but it is already diagnosed by a radiologist with the appendicitis. So
okay, sir.
Yeah.
And as I would like to consider it as an emergency, and shifted to the operation theater. In the operation theater, checking the anesthesia machine, doing the cockpit drill, getting my difficult airway cart, everything kept in place, and a neonatologist and an obstetrician in place for the management. And I would keep the operation theater warm. And
what are the anesthetic difficulties in this patient? So what are the difficulties you are going to face in regard to the providing anesthesia? So,
sir, yes, sir.
If it is the plan of anesthesia, right? So what's your plan?
It will be my plan of anesthesia would be general anesthesia with controlled mechanical ventilation with an endotracheal tube intubation.
So what are the difficulties you are anticipating?
So first is, since she is coming in for severe pain, having abdominal pain and signs of acute appendicitis, dehydration, finding an IV line might be starting to will be a difficult challenge. So once that is secured, then my next is positioning the patient in the lateral position, so that whatever the things are being done, I would like to keep her uterine placental flow in a very optimal condition, maintaining her blood pressure. Second is the most difficult of what I would like to plan is her difficult airway. Since I've already called for help, I would also ask for a trained assistant, and I would, based on her fasting guideline, fasting status, I would always do a rapid sequence induction for a pregnant lady coming in for procedures during the antepartum period.
Does the fasting strictly will change the fasting? Her hours of fasting, does it change your plan for giving rapid sequence induction?
No, sir, because she is a pregnant lady.
Yes.
Whatever is her fasting, I would like to do a rapid sequence induction. And rapid sequence intubation as well as difficult airway, they don't go hand in hand because both are going to coincide with each other. Sometimes it becomes more difficult with the pressure given in the cricoid. So I'm keeping a fiber optic video laryngoscope both in place. And
before that, how are you going to position the patient in the on the anesthetic or on the table where you're going to intubate the patient?
So
what will be the do you want to put her in any particular position so that it's easy for you to
roll under the shoulder, sir? I don't know the exact.
Okay, you can put something called
Will
an
be-
Oxford pillow.
Yes,
which
sir.
is touching, yeah, so that the ankle will be much better for you for intubation, and you can yeah, go ahead. Yeah, please.
Yes, and she would also get a left lateral tilt, a small IV fluid, or a this one is placed right. Sorry, I'm confused. So it is she gets a lateral tilt. A wedge is kept, sir. Wedge is kept below her right hip, so that IVC collapsibility is reduced. And sorry, and then coming to her intubation, as the position is keeping a roll under her shoulder and a good pillow. I would like to use a video laryngoscope. Sir, hello, sir, you can. Yeah, and she's more prone for aspiration because of pregnancy induced reduced lower esophageal. Though I'm doing our rapid sequence induction, I would also like to give her a prophylaxis for anti aspiration prophylaxis of proton pump inhibitors like pantoprazole 40 mg stat before I start off with the exact intubation induction process. Do we still talk about that 0.3 sodium citrate molar?
Yeah, you can.
0.3%, 0.3 molar,
yes.
yeah, 0.3 molar sodium citrate, 30 ml prior to the induction is used. Sorry, sir, I've not used it, so
no problem.
I'm not sure. And once I'm able to, I will be expecting a difficult airway because of the pregnancy. Second is her condition. Right now, she is in acute pain. She might not be in a situation to help me to assess her airway. Third is it is coming in as an emergency. So I would also keep an
so now the patient is so now okay. Now just so you keep the mask. You ask her to take deep breaths for how many minutes? Around 3 minutes.
3 minutes, sir.
Yes. And then you start inducing with and.
Hey. Sir, we are using propofol here for, and I'll be using propofol at 1 to 2 mg per kg body weight, and with the after that followed by, once the propofol has reached the IV cannula state or there is loss of apnea, once the propofol has been started, I would like to ask the assistant to give the pressure of 40 RSI for the along the cricoid on the cricoid cartilage, so that it occludes the esophageal opening. And the pressure is increased as the induction process is complete. Then we are using succinylcholine 1.5 mg per kg body weight as a bolus, and following which there are some fasciculations. Once the fasciculation passes off her face, the upper body, we would like to intubate her. This happens usually within 10 to 15 seconds. And intubate her, once the tube is in place inside the trachea, cuff is inflated, and then only the assistant is asked to release the pressure. And then I would like to connect her for the check the ventilation and fix the endotracheal tube, sir.
And what is your ventilation strategy?
Sir, pressure regulated volume control ventilation. I would like to keep airway pressures of around 30 to 35 and tidal volumes of around 3 to 4 ml per kg body weight, with a minor PEEP of around 3, because she already will have some basal atelectasis in the pregnancy.
And is there any does the pregnancy affect any of the drugs which you give, like the induction drugs, the
Yes.
succinylcholine or the volatile anesthetics? If you can just briefly.
Placental transfer. Is that what?
Other than that?
Sir, volatile anesthetics are known to cause uterine relaxants. The propofol and all would cause hypotension, hemodynamically hypotension, but I would like to keep the pressures under the fall of the blood. Succinylcholine.
So because the during pregnancy,
yes, sir.
Anyone else wants to?
There is during the pregnancy there is a decrease in plasma cholinesterase.
Yes. Yes.
So, but then because of that, choline may have a prolonged action, but
yes.
But again, it is compensated by increasing the volume of distribution. So, eventually, you can give her a 2 milligram per kg dose, which is routine and can achieve a good
so we don't have to reduce
conditions.
The dose. That's what we don't have to. Yeah. Okay. Okay. Dr. Kritika, so can you tell me about the analgesia part in during intra-op and the post-op period for this particular patient?
Yes, for this particular patient, I am using fentanyl, sir, 1 to 2 micrograms per kg body weight as an perioperative analgesia. Following which, I would like to cover her with paracetamol 1 gram TID. NSAIDs like diclofenac 75 mg IV.
So what about NSAID? What is your, are you happy with NSAID, or is there any careful consideration you have to do?
So yeah.
So it is better to avoid NSAID in these patients. So because I'm more concerned about even as far as the patient's concerned, and then because they can cause a respiratory problems, have spasm, and then as far as fetal concerns are there, it can lead to closure of the PDS, patent ductus arteriosus.
Okay, we just need to mention that it's not mentioned don't give, but you should carefully consider it. So if you have any other options, of course you can mention that first. So, and is there any role in regional anesthesia, like blocks or anything in this particular patient for pain control?
Because there will be enlarged uterus, there are chances of hello.
Yes, I can hear.
So giving tab block and all will be a difficult task because of the enlarged uterus covering the surface. There are chances of injecting the drug into the amniotic cavity or into the uterine surface. So I would prefer not to use any regional blocks for her.
But if you are using an ultrasound guided
Yes,
regional
sir.
anesthesia, probably
In fact, it will be more beneficial to
Yes.
use a regional
Yes.
technique along
We
with
can
the
use,
general anesthesia. That will reduce
TAB
my
block.
general anesthesia drug as well and give the good analgesia.
Exactly.
And as far as
So-
central neural blockade is concerned, it will be depending upon the coagulation profile and coagulation status of that patient, that particular state. But regional is will help me to have a good post-op analgesia as well as apart from it.
Sir, one thing,
Yes.
Jitendra sir, one thing. Sir has mentioned that the giving TAB block will reduce the intraoperative doses, but while giving GA for pregnant patients, we don't give TAB blocks or the regional blocks just after
Prior
induction,
to the surgery.
because
We give it always after the surgery, no, sir.
yeah,
Yes.
and we wish, and the Dr. Kritika, you I don't know, failed to mention that while the patient is, you're preparing for the patient for induction, you will ask the obstetrician to paint and drape the patient and well prepared.
No, sir.
Before
This
start.
is not for a pregnant lady coming for section. This is for lap appendix who she's coming. She's not coming for a cesarean.
Yeah. Okay. Yeah, sorry. Sorry.
No, this is
Yeah,
actually
and I
for
would only one thing.
non-obstetric surgery. It is.
Yes. So one thing is I forgot to tell was I would always constantly monitor the FHS, and while
Very
taking
good.
the
So
consent.
that is why
yes.
that is why we are referring the patient to the obstetrician. That you had mentioned
Yes.
actually. You refer the patient to the obstetrician before the surgery, and also you will inform the neonatologist, because those are the things which we have to do prior to taking her into the theater.
And in the consent also, I would like to mention the loss of pregnancy loss. There can be chances that there can be pregnancy loss during the procedure. So
Yes.
that is one important thing in the consent which I have to mention.
Okay. And while we I think we already discussed about the. Just wanted to ask what is the effect of the progesterone on the respiratory system in such a patient, in a 20 weeks pregnant lady? Dr. Kritika, can you just tell me?
Increases secretion karana मतलब no you know rest
it is respiration and progesterone. It causes smooth muscle relaxation. Progesterone.
Anyone can just
Progesterone, sir.
Progesterone increases the thoracic volume, the diameter of the.
yes.
It increases the diameter of the chest, so it increases the compliance of the thoracic compliance, basically. And
but thoracic compliance will be decreased because of her enlarged breast.
And it also
fat
sensitizes
absorption.
the respiratory centers to changes in the partial pressure of carbon dioxide. So
Yeah,
this coupled
yes,
with the increase in carbon dioxide production, which occurs during pregnancy, leads to an increase in the minute volume. And the pregnant woman develops a respiratory alkalosis due to increase in minute volume, because her respiratory rate also increases. So during an anesthetic, this normal physiological adaptation should be maintained. So that's what we have to keep in mind when we set the ventilatory settings for a pregnant patient in the surgery. Okay. And regarding the cardiovascular effects of pregnancy, we already have mentioned before itself. And regarding the post-op analgesia, like the regional blocks, we can mention about the analgesic parts, and we can also mention about PCA, patient controlled analgesia. I think in this side, the use of PCA is not that common, but we have to go in detail with the PCA if they ask, because PCA is very much used outside.
With opioid, no, sir. PCA with opioid is known, since they would be crossing the placental barrier. They would lead to reduced fetal movements.
In 20 weeks,
and all,
but
during
it's still inside the uterus.
That's what.
So we can easily.
It is anxious to the. Because we tried using it to 2-3 patients and they came up with reduced fetal movements causing anxiousness to the mother. Something went wrong with the PCA fentanyl, which we used. So we stopped using PCA.
Yeah, but I think for the exam sake, I guess it is.
Okay, sir.
We can always mention about PCA. That's what I think, because they are anyway going to ask about because pain is a
PCA.
big problem
Yes.
outside. So anyway, they will ask about it, how you will manage regarding the pain, and considering it is a pregnant lady as such. Okay, so I'll just move to, and regarding the DD for abdominal pain, so one thing I wanted to tell, please try to divide it systematically. Like, like I think you already mentioned it like that, but just to be on, more like non-obstetric causes, obstetric causes, infectious, so traumatic, or, you can be just organize your things better, so that it will be easy for you. You can finish off the answer fast rather than, okay. So the next question, who wants to, anyone else?
May I? May
Yes,
I, sir?
please.
Thank you.
So 25-year-old.
25.
Yeah, please go ahead. Yeah.
Sorry. Yeah, 25-year-old pregnant woman at 35-week gestation admitted to labor ward with a blood pressure of 180 by 110 millimeters of mercury. She is known to have preeclampsia and there is a plan to deliver her baby within the next 24 hours. So the first question is, what is the definition of preeclampsia?
Yes.
So preeclampsia is any new onset of blood pressure after 20 weeks of pregnancy, and that blood pressure should be more than 140 by 90 millimeters of mercury, along with the significant proteinuria that is more than 300 milligrams in 24 hours, or the protein to creatinine ratio of more than 30 milligram per millimole. And the second question is,
what is eclampsia then?
Pardon, sir?
What is eclampsia? If
eclampsia. So eclampsia is basically the patient with having preeclampsia. When the patient is having severe, it's a kind of severe preeclampsia, having seizure episode. That's called eclampsia. Now, the symptoms which this patient have, like the patient can complain of respiratory, we can divide into systemic wise. Yes. So this patient, regarding airway, this patient can complain of hoarseness of voice, heaviness and hoarseness of voice, which signifies that the patient may have laryngeal edema. Then the patient, regarding respiratory, the patient can have pulmonary edema, so patient may complain of respiratory difficulty. Regarding cardiovascular system, we can have that patient blood pressure is high, which can cause the blood pressure is already high. This blood pressure, regarding neurological symptoms, it can cause vision disturbances, hyperreflexia, and headache. The patient may complain of headache. Yes. Then the GI symptoms, patient may complain of pain abdomen, upper pain abdomen. And the patient may complain of edema, facial edema and the pedal edema. So these are the
epigastric tenderness.
The pain, yes. Upper pain abdomen, epigastric tenderness. So these are the main complaints that patient came with.
Okay. And what are the risk factors for preeclampsia?
So the risk factors of preeclampsia, like we can divide it into the demographic factors, which includes the maternal age of more than 35 years and the black race. Then we can divide into the the next category can be the obstetric causes, which includes multiple gestation, previous pregnancy having preeclampsia, and the history in the family of preeclampsia.
Very good.
Then the patient have placental abruption, intrauterine fetal growth retardation. This can cause. Then the maternal diseases, medical diseases like obesity, diabetes, renal dysfunction, hereditary from mole. This can cause then some paternal factors, like if the father has nulliparous father, or if the partner has fathered a preeclamptic pregnancy in another woman. So these are the risk factors.
Okay, and autoimmune disease as well. So
yes, sir.
Yeah.
Autoimmune disease like antiphospholipid.
You just missed out one
SLE.
point, so just one. Yeah. Okay. Okay. Can you describe the maternal complications of preeclampsia?
So the maternal complications of preeclampsia, first of all, the patient can, like, especially divided against the system wise. So the airway, patient may have airway edema. Then the patient, as the oncotic pressure, plasma oncotic pressure is reduced, along with the leaky capillaries, the patient may present with pulmonary edema.
Yes.
The patient may have pulmonary edema. Then the then itself in the neurological CNS, the patient may present with hyperreflexia and seizures episode. Then fetal problems like intrauterine fetal growth retardation, IUGR. Then hematological problems, patient may present with coagulation disorders with like HELLP syndrome, which includes the hemolysis, elevated liver enzymes, and low platelet count. One more thing regarding neurological is posterior cerebral reversible leukoencephalopathy, PRESS syndrome.
And even intracranial hemorrhage can also happen.
Yeah, ICH.
And,
yes, sir. ICH
and obstetric-wise, placental abruption.
Yes, sir.
Yeah. Okay. So, and what are the fetal complications when the mother?
Fetal complications are basically the fetal blood supply is hampered because of this abnormal placentation. So it causes intrauterine fetal growth retardation, IUGR, and may lead to IUD, intrauterine death.
And amniotic fluid wise, there will be a decrease, so oligohydramnios. Then there can be a hypoxia from placental insufficiency, and there can also be chances of preterm delivery.
Yes.
Okay. So now, what are the important priorities in her when lives on the? So before going into that, what is the treatment for preeclampsia when she comes for regular checkup and to the obstetrician? So what is the treatment for preeclampsia?
So so the treatment for preeclampsia, the ultimate treatment is the delivery of the fetus in the placenta. So this is the ultimate treatment. But if the patient has not attained that gestation level, then we have to treat the blood pressure. That will not control the progression of disease, but that will control the blood pressure only. So the tablets, the medications which we can use is, first line is injection labetalol, preferably IV, or oral, depending on the blood pressure. So oral we can use in the dose of like 100 to 600 milligrams in divided doses. Or 100
this is
to 100
which one you're
milligrams.
saying? Sorry.
Sir, labetalol.
Labetalol. Yeah. Okay.
This is the first choice of drug.
Okay.
Labetalol, which can be given oral or IV depending on the blood pressure. Oral is 50 to 200 milligrams depending on in divided doses, and IV we can give in 5 milligram boluses followed by infusion. Then the second line drug is injection hydrolysine, which is given only IV, which we can use IV use. Then we can use labetalol, hydrolysine, methyl dopa, and the last drug is
any calcium
then
channel
we can
blocker?
use magnesium. Then yes, we can use magnesium sulfate.
Calcium channel blocker, nifedipine.
Yeah, nifedipine. Yes, nifedipine. We can use oral nifedipine also. Then magnesium sulfate we have to give to control the blood pressure and to prevent the eclamptic seizures. The dose is
So that when do we
Or-
consider magnesium? Do we consider it in pre-eclampsia itself, or when do we consider giving magnesium?
Preeclampsia with severe features like severe preeclampsia. So this blood pressure of 180 by 110 millimeters of mercury, we will give magnesium sulfate because it will prevent also. So we have to give prophylactic magnesium sulfate also along with the treatment. So we will give magnesium sulfate in the dose of 4 grams IV over 10 minutes, followed by an infusion of 1 gram per hour.
Okay. And what are the important considerations before we, if a patient with preeclampsia comes in for labor epidural, what are our considerations?
So if the patient of preeclampsia comes with a labor epidural, definitely we'll give it an option because it will decrease the catecholamines related, pain related catecholamines, and that will help the patient's blood pressure to come down. But we have to weigh the risk benefit ratio. The benefit I have told, the risk associated may be the patient's coagulation. The patient's coagulation may be hampered because of thrombocytopenia and the clotting factors deficiency. So we have to check accordingly if we can plan if we could put the epidural catheter.
So in clotting factors, so what are the things we are going to check?
First of all, the platelet count, preferably.
Yeah, how much?
Preferably.
So what is your target like?
It's 1 lakh, more than 1 lakh per cubic millimeter. Okay. For epidural to be cited. Then
if it is 90,000, will you do a labor epidural?
Sir, actually, it's a gray area.
Yeah.
It's a gray area. So
we avoid if it is strictly below 80,000. We can do it between 80 to 100. We check for the other parameters like the INR. Yes, Dr.
PTINR and APTT.
These patients are usually put on ecosprin, 150 ecosprin or about 75 ecosprin because eclampsia, preeclampsia, and they're always put on ecosprin. So platelet dysfunction is expected.
Okay, I will come into that now. Thromboprophylaxis, Dr. Deepak, what are your considerations regarding the thromboprophylaxis? Do you think ecosprin will be a problem for you to provide labor analgesia for this patient?
No, sir. Low dose ecosprin is not considered contraindications for epidural or spinal intrathecal injection. So if the patient is on low dose ecosprin, we can go ahead with this.
And if the patient is on any other thromboprophylaxis, what are the things you have to consider?
Patient can be on low molecular weight heparin. So then prophylactically, if the prophylactic dose we have to avoid for 12 hours before citing an epidural.
And if the patient is receiving a treatment dose of low molecular weight heparin,
then 24 hours we have to stop at least for 24 hours.
Okay. Okay. And what else can labor epidural do to the? So you said that reduction in the catecholamine release, so reduction in the maternal blood pressure. So that is one good thing for this. Anything else? It improves the placental perfusion. So that is another advantage, and it also gives an option to avoid general anesthesia in this patient if it requires.
If the patient is later on required cesarean section, we can convert into the.
So what are the important considerations we take when we take the patient with preeclampsia for the surgery, cesarean? So that's the next. What are the important priorities in him when she? If we decide for a cesarean section, what are the considerations?
So, different considerations according to the systems. Again, we come to the airway. These patients are considered difficult airways because of edema and the mucosal involvement. So we have
and the patient has insist on having general anesthetic. So she has refused central neuraxial blockade. So then.
So first of all, the airway. These patients are considered a difficult airway. So we have to prepare our difficult airway part, and we have to manage accordingly. Then regarding the respiratory system, these patients tend to go into the pulmonary edema very fast because the plasma oncotic pressure, which is lower in pregnant females, it becomes much lower in the pre-eclamptic patient. So the fluid strategy we have to maintain according to the input-output chart. So we can use a central venous pressure guided fluid therapy. So we can limit our use to 80 ml per hour with a target output of 0.5 ml per kg per hour. Hello.
Yeah, I can hear.
Yeah. Okay. Yeah. So then these patients, because of pulmonary edema, they may require a higher ventilating pressures. So we have to keep in mind, and we have to keep them on slightly respiratory alkalosis till the baby delivers. And then the cardiovascular system, we have to keep the target blood pressure of around 150 by 100 millimeters of mercury. So we can use different drugs accordingly. Preferably IV labetalol we should use. Then the consideration of
coagulopathy, we have to
coagulopathy. Hematology. In hematology, the patient may have anemia, so we have to get the full blood count, and we have to order for the cross match in the safe. Then the patients may have low platelet count. Then the patient coagulation profile may be deranged. We have to consider that also. And we have to arrange the blood products, different blood products accordingly.
So as I told, we are giving a GA. So any consideration regarding the neuromuscular blockers?
Yes, sir. I was coming on that. So then the patients may be receiving magnesium sulfate, or so the patients the dose of succinylcholine. Theoretically, these patients have low pseudocholinesterase activity, so they should have a prolonged duration of succinylcholine. But because of increased volume of distribution, this effect is neglected. So we can safely use the succinylcholine in the dose of 2 milligrams per kg. But we should give a non-depolarizing neuromuscular blockade once the effect of succinylcholine is reached. Then if the patient is on magnesium sulfate, then it prolongs the effect of neuromuscular blocker, non-depolarizer. So we have to keep in mind. So we should use neuromuscular monitoring for these patients.
What is an alternative for succinylcholine in a patient like this? For you are supposed to do a rapid sequencing.
If we have if we have availability of Sugama Dex for rapid reversal, we can use rocuronium in a dose of 1.2 milligrams per kg.
For rapid sequence induction, yes.
Yes, sir.
Okay. And now we are into the surgery, and they have delivered a baby. And so after we finished the surgery, we extubated the patient. We are shifting to the post-operative ward. Yeah. Okay. Am I audible? Yeah.
Yes, sir. Yes, sir.
Yes, sir. Very well.
So the patient is in the post-operative ward, and all of a sudden she develops seizure. Now, what will be the management? She's already in the post-operative ward, and she develops seizure. And not in the ward, post-operative ICU, and she develops seizure.
Okay. So now this patient has developed seizure. So I'll declare it as an obstetric. I'll declare it as obstetric medical emergency, and will ask someone to go and call for help. And I have to make a a differential diagnosis for this seizure. So it could be like obstetric cause and the non-obstetric cause. The obstetric cause could be like obstetric neurological causes. It could be eclampsia. Then it could be intracranial hemorrhage. It could be subarachnoid hemorrhage. Then the non-obstetric neurological causes could be the patient may have a previous history of epilepsy. Then the patient may have some intracranial space occupying lesions already. It was there. Yes, so this could be non-neurological, non-obstetric neurological causes. Then this patient, as the patient was done under general anesthesia, so it could not be the effect of anesthesia. Then what else? So after establishing the cause, like if I made a cause that it could be eclampsia, I'll start with my EBCD approach. I'll assess the airway of the patient. I'll take control of the airway if the patient's airway is not maintaining the airway. Then I'll start the high flow oxygen mask. After checking the vitals, I'll put the patient on the high flow mask. Then I'll assess the circulation, like what are the blood pressure, what is the heart rate, and as already there will be IV cannula secured, so I'll rush an IV fluid. Then I'll start the definitive management. I'll give a bolus of magnesium sulfate of 4 grams IV over 10 minutes, 4 grams IV over 10 minutes, followed by 1 gram per hour infusion. If the seizures are not controlled, I can give a bolus of 1 to 2 grams in 10 minutes. Repeated.
Okay. And okay, so any investigations will you plan for this patient?
Yeah. So along with this, meanwhile, I'll send the blood for complete blood count, urea and electrolytes, and liver function test, and the coagulation screen.
What are the signs of magnesium toxicity? So what are you aiming at, what values, and can you tell me?
So the normal magnesium levels in the blood are 1 to 4 millimoles per liter. So we have to check regularly the deep tendon reflexes to check for the toxicity and order the magnesium level also, blood magnesium, serum magnesium
only
level.
The deep tendon reflexes or any other parameters as well?
So deep tendon reflexes along with the serum magnesium level. Yes,
and respiratory rate.
Yes, sir. Yeah. So at different levels, like if the DTRs are the earliest to lose. So if the patient is not having patellar reflex, then the level is above 5 millimoles per liter. Then above 7 millimoles per liter, the patient can have respiratory distress, difficulty with respiration. Then above 7.5, patient may go into cardiac arrest. Like, and if
above 12,
above 10 is going to cardiac arrest. Yes.
Yeah. Okay. And anything else can we give for magnesium toxicity?
Yeah, if we are suspecting a magnesium toxicity, then again we have to stop the magnesium injecting magnesium. Again, call for help. Stop injecting magnesium, and then we have to give calcium gluconate 10 ml, 10% stat.
And we also it's better to secure the airway until we think the patient is safe to be extubated because of the respiratory depression. Okay. Now, coming to, so since we already explained about the epidural and spinal, so this a patient who had a spinal cesarean under spinal anesthesia came with a headache 2 days postpartum. So I'm just going into the complications. I mean, what are the differential diagnosis of the headache in a patient with headache 2 days postpartum?
So this postpartum headache, again, the differential diagnosis could be the patient obstetric causes and the non-obstetric causes. The obstetric causes could be patient because of intracranial hemorrhage. Then the patient can have post-dural puncture headache. Then the non-obstetric causes could be the patient have a simple headache. Then the migraine. Then the patient can have a migraine.
Metabolic issues like dehydration, withdrawal, opioid withdrawal, so
caffeine withdrawal, caffeine withdrawal, and the dehydration. Yes.
And other reasons like stress, history of preeclampsia, and lactation headache. That is another entity we tend to miss. Okay, now since the patient, so how do you come to a diagnosis of post-dural puncture headache? What are the characteristic features in
so on the basis of the clinical features, usually it starts 72 hours after the intrathecal injection. The distribution is typically fronto-occipital. Associated with the patient can complain of blurring in the vision, photophobia, neck stiffness, then the nausea and vomiting. Then the specific relieving factor and the aggravating factor, the patient may say that when the patient lie down, it's relieved, and the patient stands up, it is aggravated. So these are the specific features which suggest that the patient can have a post-dural puncture headache.
Okay. And how do you like any investigations you would require for such a patient?
To rule out other causes.
Exactly. Just to rule out the other causes.
Yes, sir.
Yeah. So what are the investigations? Do you know?
We can order an MRI. MRI brain. That is or the CT head. NC-CT head. Now the patient is already delivered. So the CT head we can order to check for the hemorrhage.
And full blood count and CRP to rule out any infections causes or anything.
Yes, sir.
Yeah. And what is the management for post-dural puncture headache?
Yes. So first of all, the management is the reassurance of the patient. Then the patient, we can start with a simple analgesic like non-steroidal anti-inflammatory drugs. We can ask the patient to take rest and improve the hydration, have an adequate hydration. If the patient's headache is not relieved with these maneuvers, like in 4 to 5 days, we will advise the patient go for epidural blood patch.
Okay. How do you do a epidural blood patch?
So the epidural blood patch will first of all explain the patient the risk associated. Then after that, we'll go with the procedure. It needs minimum of 2 anesthetists, and one of them should be consultant. Then one anesthetist will be withdrawing the blood, and another anesthetist will locate the epidural space, one space below, or the same space, or the space below on which it was injected previously, and 20 to 30 ml of autologous blood is injected in the epidural space.
Okay. And do you have any complications with this epidural blood patch treatment?
Yes, sir. Yeah. So the complication associated could be the infection. Again, there is risk of accidental dural puncture, failure to resolve the headache. Then the patient can have infection.
There are chances of irritation to the meninges and also seizure.
Irritation to nerve damage. chance.
Yeah. Okay, this is just the last topic. I'm sorry, I'm going. Should I stop it here? Please let me know. This is just one more topic I have. Is it okay? Can I continue or?
Sure, sir. Sure, sir.
Okay. So obstetric hemorrhage. So what are the? Anyone else wants to volunteer for obstetric hemorrhage?
Yes, sir. I'll volunteer.
Yes, please. Okay. Can you tell me the different types of obstetric hemorrhages?
So obstetric hemorrhages, broadly can be classified as a antepartum and postpartum.
Okay.
In the antepartum period, depending on the when it is occurring in the early period, if it is occurring, it can be because of sepsis or because of abortion, and then it can be because of ectopic pregnancy also. And if it is occurring in a delayed this thing, then antepartum can be because of abruptio placenta and placenta accreta, and then postpartum hemorrhage is because of atonic uterus or a written pregnancy product or written placenta or inversion of a uterus. So
Okay.
these are the causes of bleeding in the pregnancy.
So this postpartum hemorrhage, you can divide it into primary and secondary. So primary
Primary
is
and secondary
24 hours.
within 24 hours, and secondary up to 4 weeks. Sir.
Yeah, after 24 hours. So, these are the causes for antepartum hemorrhage. It can be, as you rightly said, placental abruption, placenta previa, trauma, uterine rupture. Intrapartum hemorrhage can be genital tract bleeding during labor.
Genital tract. Yeah.
Primary partum hemorrhage can be due to uterine atony, retained products of conception, genital tract trauma,
Inverted uterus.
clotting defects, inverted uterus. And secondary PPH can be due to retained products of conception and puerperial
sepsis.
So what are the risk factors of postpartum hemorrhage?
So risk factors for postpartum hemorrhage is maternal risk, fetal risk, and uterine risk. So maternal risk is multi-gravid, then overage patients above 30, 35, 40 years of age. Then hypertensive patient or patient having other comorbid disease. Then fetal is IUGR or meconium in the uterus. Then as far as or then any condition which causes the overstretching of the uterus, then prolonged labor, and as far as placental is concerned, placental abnormality, placenta accreta or anatomical position of the placenta, or then chorioamniotis or that kind of conditions which can lead to chances of causing postpartum hemorrhage.
These are the risk factors. And what are the do you know the causes? How to the causes of postpartum hemorrhage?
Pardon, sir?
The causes, like so you have to, when you tell the answer for the causes of hemorrhage, you can tell it as the divided by the tone of the uterus. The uterine muscle contracts to prevent the bleeding, so uterine atony can cause the postpartum hemorrhage. Then another cause is the tissue. So it is like a mnemonic, T, 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 and C. So I'm just saying it. Retained or membranes in the uterus. And then the third T is trauma, that is vaginal or cervical laceration. And last C is the coagulation defect. So this way it's easy to remember.
Yes, sir.
Okay. And so what will be the management for in case of PPH?
So PPH is a obstetrics and anesthesia emergency, sir. So it has to be. I'll declare it as an emergency call for a help,
Yes.
and I will go. My assessment and my resuscitation will go simultaneously. I will have a assessment regarding the amount of blood loss. I'll check the sheets. I'll check the blood clots, vaginal blood clots, and I'll see the pulse, blood pressure. Then I'll also send the blood for CBC and coagulation profile, and as well as urine also simultaneously. And my resuscitation will be as per the ABCD approach.
Yes.
I will start the oxygenation, and if consciousness is doubtful, I'll not hesitate to go for securing the airway, and I'll send meanwhile I'll send the blood for cross matching, and I'll demand blood as well as FFP and cryoprecipitate, and I'll inform senior as well as obstetrician and ask to ship the patient in the OT.
Any particular blood group you will ask for immediately? Can you wait for the cross match?
If I go for urgent cross matching, it is fine. If the urgent cross matching facility is not available, I'll go for a universal donor. O positive blood, sir.
O negative.
O negative.
O negative. Sorry, O negative blood, sir.
No problem. No
O
problem.
negative blood.
Okay. And any other particular test do you send for? I mean, which can be immediately, which we can procure in a large center probably, other than sending for coags, blood, any other thing? TEG, yes, thromboelastogram. So
thromboelastogram, TEG
yes,
bedside
yes.
can be done.
Which
bedside.
can guide you better in the in terms of what products to give.
Yes,
yeah.
sir.
So even though we might not be using it in many institutions here in India, they might ask about thromboelastogram. So please go through thromboelastogram. And so monitoring wise, what all we will be doing all the basic monitoring. Other than that,
basic monitoring.
Any other thing we will be doing? Any invasive monitorings?
I'll like to go for a central securing the central vein as well as arterial lines in this patient, and I'll like to take the peripheral large bore cannula for a rapid infusion of the blood and blood products, and then I'll start the treatment like in association with obstetrician. It will be like drugs to contract the uterus.
Yes.
So in which there will be a oxytocin or like
uterotonics. So what are the uterotonics you will give?
So I'll start with oxytocin. If it is not responding to oxytocin, then I'll not hesitate to go for a ephedrine or a prostaglandin F2, that is a carboprost. Keeping in mind the complications which they can arise, but here the primary aim is to contract the uterus and prevent the bleeding.
How much carboprost will you administer?
To start with, I'll give 250 microgram, and then I can repeat it 125. Sometime like if my obstetrician says they can, they prefer to inject intrauterine as well to have a better contraction of the uterus. And if it is not responding, then there are surgical interventions which are advised to reduce the further blood loss, like internal iliac artery ligation, or then even informing the relatives regarding the dire emergency of the situation, and last resort to go for hysterectomy, obstetric hysterectomies.
Any role for interventional radiologist? Anything?
We can plan for interventional uterine artery obliteration with the help of spring or thrombolysis with the help of spring.
Okay. So when we tell about the management, we can divide it as medical and surgical management. So initial medical management, as you rightly said about uterotonics. Other than that, the obstetricians will be doing a bimanual compression or
Bimanual compression
and also tranexamic acid. You should
tranexamic acid.
yeah, there is famous trial called women's trial on tranexamic acid. So
yes, sir.
don't miss out on tranexamic acid and the dose of tranexamic acid. And then surgical approach comes. It is uterine massage, uterine tamponade with balloon or a pack,
Tamponade with balloon.
uterine this thing or
artery ligation.
artery ligation, B-Lynch suture, hysterectomy, and intervention radiology.
Interesting.
Okay, so these are the drugs which we start with: sintometrin, oxytocin,
oxytocin,
oxytocin infusion, carboporous, and misoprostol. I think you missed out on
misoprostol. Misoprostol is or transvaginal.
Yeah. Okay. So now about the transfusion part. So what will be your plan for immediate? So once you cross match it and you receive the blood, what will be your plan? Like, what will be your therapeutic targets in regard to the blood parameters?
So my therapeutic target will be to maintain the hemoglobin level. My aim will be to replace 1:1 blood, and for as it will be a massive blood transfusion, so simultaneously I'd also like to give FFP to these patients for maintaining the coagulation, as they are very much prone for DIC. Then and along with that, I will also keep infusing the colloids, crystalloids, sorry, not colloids, crystalloids along with the blood.
Okay. So just I think we don't have much time to talk about the blood transfusion and related issues. So they might go deep into blood transfusion regarding each product, and also about the complications of blood transfusion, like
massive blood transfusion,
and all those things. There are many. There are immediate complications and late complications. You have to divide that for blood transfusion. And this thing also, they might ask thromboelastogram. I didn't personally get it, but there is a chance, because it is becoming more popular now. So try to, they might ask you to draw the thromboelastogram and label it. So it is better if we can learn, because as an obstetric anesthetist, we are all supposed to know about the thromboelastogram. Okay.
Yes, sir.
And about multiple blood transfusion protocol, please go through the latest guidelines. What are the guidelines on massive blood transfusion? Sorry, not multiple, massive blood transfusion protocol, and we can answer accordingly. Now, one more thing I wanted to, I think we are already, it's 9:30. Just wanted to go on with about talking about the failed intubation. So, okay, can I go with the last one? This one as well, please? Is it okay, or?
Can I ask one question?
Yes, please.
Before that? Like while giving general anesthesia for cesarean section, we usually don't give fentanyl, like opioids for that sake, before delivery of the fetus. But in the podcast, they have mentioned that fentanyl or opioid has to be given, and we have to inform the neonatologist that we have used the opioid and the suspected neonatal respiratory depression. So what we should mention, like we have to give or we should avoid it?
No, we can always say we avoid, because that is how we manage here. So it is better, you can say we don't give, but there are conditions when the patients might have received already opioids from the labor ward, from the labor room, because as you know that labor analgesia is not just labor epidural. It can be PCF, fentanyl. They can give pethidine. So actually, they say that even if we give fentanyl, there is it's okay in terms of to alleviate the intubation problem. So that's why basically we give fentanyl, right? So we can
Yes,
do
sir.
that. We can always inform the neonatologist. There is no harm if you can answer like that. There is no issue because you are already informing the neonatologist about it. But even if you miss out on it, they are not going to decrease your score. That's what I think.
So we can answer both ways.
Sir,
Like if we are
We can
giving
answer,
it,
but if
yeah,
you say that you are giving fentanyl, you have to tell the point that you will inform the neonatologist
we have to
about it.
justify why we are using the fentanyl to alleviate the laryngoscopy response.
Exactly.
Okay.
Exactly.
Thank you. Thank you.
Yeah.
Sir, in one more question I want to ask. Like, here routinely, I am in most of the emergency and compromise ASA grade 3-4 patients. I am routinely, when they are doing painting and draping with the sonography guided, I am routinely giving tab block immediately before they take the incision. So that is helping me. So can I mention it, or like it is only for post-op analgesia only?
Yeah, I think it's better you can answer it as in post-op analgesia because we don't want controversial things to be brought up while we are answering, because it's always better we
Okay, sir.
keep those things behind. Like I
Got
had
it, sir.
earlier, I think I had mentioned it somewhere. This is an instance I'm saying. For my exam, they asked me about labor analgesia and they asked me about remifentanil. So I said I haven't used remifentanil because where I am working and there is no remifentanil. But the examiner immediately told me this is an exam and we are expecting you to answer the questions as in the exam. So that was one point where it just click, because it's an exam. So of course we can answer what all we practice, but as long as it is safe when we answer. So
Yes, sir. One more question about remifentanil. So in the
Yeah.
podcast, they have mentioned the PCA remifentanil.
Yeah.
But in the master pass, they have mentioned that we have to avoid remifentanil because the studies have proven it to be detrimental. So we should avoid remifentanil. So
in both the books, I think it is a bit little old. So I would suggest that regarding remifentanil, regarding the labor opioid analgesias and the PCAs, please go through the latest guidelines if we can go through.
Yeah, latest guidelines. It is
And
advanced, sir.
if whatever we find in that, it's better to answer in that way. So
Okay,
rather than
thank you,
going with
thank
the
you.
podcast and masterpass regarding remifentanil, regarding any newer methods, it is better that way.
Okay.
And even if they ask you when it comes towards the end, so these kind of questions you will expect only in the towards the end of the session. Even if you say that you are not very well aware of it, you only know about the earlier this thing, and you answer like that, they are not going to punish you for that. So
Okay, thank you.
So there's one more point I wanted to highlight about intrauterine fetal resuscitation. So what all we will do for intrauterine fetal resuscitation? I don't have. I think just go through the slides. Is that okay? If I just go through my last few slides, and
Yes, sir. Yes, sir.
so these are the risk factors for the difficult intubation in a pregnant ladies, other than the pregnancy itself. And yeah, so this is what I wanted to highlight. So the obstetric general anesthesia and failed tracheal intubation. So this protocol we have to by heart it, because this is what they will expect us as obstetric anesthetists to answer. So we have to be confident, fast, and we have to reply in the algorithm as such. So just I think we have to go through this. There are 3 algorithm slides. I think many of you are already aware of all these things. So, but just wanted to highlight this.
So can you please share this
Yes,
PPT
I
on
will.
WhatsApp group?
I will.
Thank you, sir. Thank you very much.
And regarding the cardiac arrest in pregnancy, so sudden collapse of a pregnant lady, that is another question that can come. So what are the algorithms for the cardiac arrest in pregnancy? So the BLS in regard to a pregnant lady. So even that we have to study. So if we can do, I think pretty much we have gone through all the topics basically about obstetric anesthetics. Other than this, only thing I couldn't explain much was about labor analgesia. So labor analgesia is one thing, they can go deep into it. They can ask about labor epidural, the method, how you give labor epidural. Will you use, so in that the tricky questions are, will you use the adrenaline with the local anesthetic as a test dose? So again, it is a gray area. People say that they don't use, they use. So just be thorough with what you are going to answer regarding that. So these are the questions which you should be prepared like to answer. Definitely it might come in one or the other way. So administering labor epidural, then what kind of drug will you use? So just tell about one drug, and if they ask any other alternative drugs to use, so you can always tell about the next one as well. So for example, if I am supposed to, I will go with ropivacaine, which I am used to. So you can always say that other than that, we use levobupivacaine or bupivacaine, and how much, in what concentration. So the concentrations we should be thorough with. And then what are the things we monitor immediately, and in every half an hour or 1 hour or every 15 minutes, what are the things we monitor once you put in a labor epidural? And what is a PECA? That is a PCEA, sorry, patient controlled epidural analgesia. So what is PCEA? So, and what are the lockout intervals and all those things you should be thorough with PCEA. And then they can ask any other method of labor analgesia. In that you come with the pethidine or Endonox and remifentanil infusion. And one more thing I forgot about, when it comes to labor epidural, you can also mention about the combined spinal epidural technique, where you give opioid or whatever, however you practice, you can explain that over there. And then what are the complications after the labor epidural? And another common question they can ask is, a patient whom we have administered labor epidural, suddenly a pre-eclamptic patient whom we gave a labor epidural went into seizure immediately after labor. So what are the differential diagnosis? Because it can be amniotic fluid embolism, it can be seizure due to our labor epidural, it can be seizure due to eclampsia. So that is another area where they can go into any discussion. They can go into amniotic fluid embolism, they can go into local anesthetic toxicity, and they can either go into eclampsia. And when they come into local anesthetic toxicity, you have to know about what are the treatment for the local anesthetic systemic toxicity. When it comes to amniotic fluid embolism, we have to explain what are the things we do about amniotic fluid. So amniotic fluid, we do all the basic life support thing. We know that potentially it may go into disseminated intravascular coagulation. We have to immediately ask the obstetrician to deliver the patient, the baby, and we secure the airway and ventilation and all those things. So we have to go in that track. If it is last, we have to tell about the complications and the treatment for last. Or if it is eclampsia, as we discussed earlier about eclampsia, how we, again, if it is even if it is eclampsia, in all these three things, we ask the obstetrician to immediately deliver the baby, because it is the best we can do. We, on one side, we try to optimize the mother, and we ask the obstetrician to deliver the baby immediately. Okay, I think it's almost 9:40. I'm keeping you guys wait for 1 hour and 40 minutes. Anything else you want to discuss or want to ask? There are a couple of questions from the chat zone.
Thank you, sir. It was a very wonderful session.
Okay. Okay. All right.
Thank you, sir. Thank you.
Okay. So there was a question on the fluid management. I think we have already discussed that, the fluid management. Dr. Narendra. Okay, so shall we stop the session? And anytime we can always discuss, and I will try to put this in the group, the slides. Yeah.
Sure, sir. Thank you, sir. Thank you. Good night.
Thank you very much.
Thank you. Good night.
Thank you. Thank you. Thank you all for volunteering. It was wonderful. Thank you.